Good evening, ladies and gentlemen. Today, my job is to specifically address the issue of cardiac sparing techniques. But to have a deeper understanding of this topic, we must first understand that why on the earth we are so concerned about cardiac sparing and carcinoma breast. Well, if we look at the etiology, it is not only radiation, there are many other factors like a baseline patient cardiac status or administration of chemotherapeutic agents or targeted agents. So, it is a combination of multiple factors which leads to cardiac mortality and morbidity. In past, way back in 1980 or 85, adjuvant radiation was associated with excess cardiac mortality, and this definitely earned a very bad name for us. Reason for same can be seen here in the radiation doses to heart, and probably because of old techniques which were prevalent at that time. But with time and improved knowledge and better technology, this excess cardiac mortality became insignificant. So in current times, risk became same as a normal population, although cardiac morbidity is still a concern. So this improvement with time can be seen in this systematic review also. In addition to time trends, geo trend showed maximum mean heart dose in publications reported from Asian countries, and reason is probably known to everyone. Limited access to resources. So why are we giving so much of importance to mean heart dose? Well, I presume we all have gone through this paper by Darby et al. Published in NEJM in 2013. They clearly showed that with every gray increase in mean heart dose, there is 7.4% increase in major coronary event over and above the baseline risk. Though they could not identify any threshold dose, and in their series the risk started increasing just after few years of starting radiation and remained high post 20 years. And recently same kind of analysis was done by Taylor et al. For modern radiation doses, including modern series, and had almost similar findings. With each gray, there was increase in excess relative risk of 4.1% with radiation, and this was though less as compared to the series as reported by Darby et al. Let's discuss one practice case scenario here. So, if a 50-year-old patient who is a smoker or had a history of prior ischemic heart disease, then a baseline cardiac mortality will increase from 8% to 9.2% by the age of 80 for a mean heart dose of 4 gray. And at the same time, for the mean lung dose of 5 gray, risk of lung cancer death will increase from baseline of 9.4% to 13.8%. So my point here is we have to look at the whole picture and should consider the overall advantage which we gain from giving adjuvant radiation in the light of offset created by patient-related factors and OAR dosimetric factors. So while assessing the risk for cardiac morbidity, should we consider mean heart dose to be surrogate for doses to all other cardiac substructures? Well, in this study, it clearly depicts the significant range of dose variation in left anterior descending artery V30 dosimetric parameter if we keep our mean heart dose at 3 gray. We can see that the dose ranges varies from 10% to 3% for the same mean dose. So the bottom line is we can't get away by not contouring the heart substructure, especially a left anterior descending artery and left ventricle. So while assessing the risk for cardiac morbidity, that we have already seen that there is an importance of contouring the substructures and reporting the doses to these substructures, because now we have emerging evidence which relates dose to these substructures and cardiac events directly or indirectly. So now that we understand that dose to these cardiac substructures matters, but do the fractionation also matters? This study explores the equidistant doses of heart for a range of alpha beta values, and they found that all hypofractionation schedules to be colder than this normofractionation schedule, represented by a diagonal solid line, except for 41.6 gray in 13 fractions. So now let's finally focus on technique and its impact on cardiac sparing. This report from Michigan Radiation Oncology Quality Consortium clearly depicts the same time trend as I showed you earlier from other series also. But more importantly, with regard to technique used, prone position and DIBH, they both resulted in 32% and 18% reduction in mean heart dose from baseline estimate, which was 1.32 gray and 1.14 gray for altered fractionation or accelerated fractionation. Factors which resulted in increasing mean heart dose were boost nodal RT years prior to 2015, increasing breast volume and increasing separation. But this was all expected. Unexpected was use of modern technique like IMRT and increase in mean heart dose. So as we use multiple beams with different entry points in IMRT and thus spill low dose to larger area, this must be the reason for this surprise finding. So if we consider a linear relationship between mean heart dose and cardiac event as per Darby et al. Or a Taylor et al., then this is really a concern. So addressing this issue, a group from Zurich led by Schneider et al. Adapted reality seriality model which was based on dose as well as dose distributed over volume, and what they found was very interesting. So adapting the Darby et al. To this model did resulted in a linear trend as shown by the original article. This is a situation like a lot to a little, as techniques used in the series included in this study was tangential fields and only a small portion of heart received the unintended dose. But using modern technique like IMRT, where situation is like a little to a lot. So this relationship became sigmoid, and in fact up to the doses of 12 to 15 gray, there was no excess major coronary events. Although this is a model, still everyone may be intrigued by this finding, but we must wait for more mature data to support this hypothesis. So this another report somehow asked the same question. So is delivering radiation, including HypoFractionation regimen with modern VMAT or a helical tomotherapy, is it safe? But they answered it dosimetrically. We can see that hypofractionation schedule delivered via these modern technique is colder as compared to normofractionation, whether it being doses to cardiac cavities or be it a cardiac vessels. But we must realize that LQ model was validated for equivalence between fractionation regimens with regard to tumor control in START A and START B. Whether same holds true for normal tissue complication or not, we should definitely wait for long-term results before jumping into any conclusion, especially with regard to these modern radiotherapy techniques. So although techniques are important, but we must understand that our target delineation approaches can impact our cardiac sparing techniques. If we look at the patterns of local recurrence among 6,901 patients in this systematic review, only 0.09% relapsed in the true chest wall and 0.8% relapsed in the PAC major and or a minor area. So if we exclude this area from our target, this results in reduction in mean heart dose from 5 gray to 3 gray. That is an absolute difference of 2 gray, which is huge in this clinical context. We also recently published our dosimetric study led by our colleague Dr. Irfan, asking whether for a given target delineation approach, is there any favorable technique, and what we found was that FIF technique scored better than VMAT and was equal to inverse IMRT if we delineate our target as per tangential fields or ISRO guidelines with regard to target coverage and cardiac sparing. And another very important question was asked that if we are constrained with technique due to unavailability or preference, does any target delineation approach is preferred? What we found was quite interesting. ISRO target delineation approach scored better than both tangential field approach or RTOG approach when we used field in field technique or target for target coverage. While for cardiac sparing, ISRO and tangential target delineation approach both scored better than RTOG. Another very important aspect is how we simulate our patient. So this approach of creating a breast shell by pushing the breast from lateral to medial and from superior medial to inferior while placing the cast resulted in substantial decrease in mean heart dose from 5 gray to 2 gray. Interestingly, this approach can be applied to LINAC or cobalt based setup without adding any substantial cost to the setup. So what about setups where we have cobalt-60 machines or a linear accelerators without any modern techniques? First of all, I would like to thank Dr. Ajit Gandhi for these images. So breast cone is something which can be used in cobalt machine, which is shown in this extreme left image as an attachment, and which can help in reducing the dose to heart by making a half beam block application easy. Other than that, we can use prone position or a lateral decapitated position, or we can block the apex of the heart. This may probably result in underdosing of the target. There are issues with approaches of these positional approaches, lateral decapitors or a prone position, as these approaches fail if we have to do regional nodal irradiation. Also, they are difficult to implement and are prone to have setup errors issues. So from patient's perspective, these are not, the patients do not have a very pleasant experience using these approaches. So to overcome this, Nicholas et al. Used the approach of reverse semi-decupitous position, where we just have to rotate the patient approximately 45 degrees and elevate the patient elevate the upper body on the press board, and patient is immobilized using a vacuum bag and is cross-legged for comfort. So this was not as good as DIBH, but for patients who were not suitable for DIBH technique, this resulted in substantial decrease in heart dose from 5.7 gray to 2 gray. Again, this is a substantial drop using just a different positioning approach during simulation. This report from Taylor et al. Reviewed the cardiac exposure in breast cancer radiotherapy for the period between 1950 and 1990. And this was a period when older techniques and machines were used, like cobalt-60. So minimum exposure to heart was when IMC field was not used and medial border was placed at a distance from the midline. So heart D mean in this particular scenario was 1 gray. You can see here. And if medial border was placed at a midline, heart dose increased to 5 gray. And if IMC was included and the fields were adjusted to include the IMC, then the mean heart dose jumped to 13 gray. So if we have to use this old technique, is it justified to include IMC? Let's see how can we approach this particular situation. So let's presume that we have a patient age 50 who is non-smoker with no cardiac risk factor. Her baseline 10-year risk of mortality by cardiac cause would be approximately 1.5%. So impact of overall survival benefit is 2% at 10 years as per EBCTCG trial, and if considering URTC IMC trial, which reported very recently their updated results, the OS benefit was 2%, that too was not significant. So what happens if we irradiate this patient with cobalt-60 and try to include IMC in the field? So offsetting survival as per Darby et al. Equation, what we are left with is only a minuscule overall survival benefit, probably a non-significant difference, and a little more increase in heart dose, we will have a detrimental effect. So to substantiate this fact, another report published recently addressed the same issue and found 2.45 times more MI in these patients when treated with older techniques and machines. So now let's focus on modern techniques. There was a great deal of evolution from 3D conformal approach of field in field technique, where first open field generates a dose distribution and then we add subfields iteratively with blocks over the hotspot area. So from this approach to approaches like IMRT, VMAT and tomotherapy. So these later techniques were used only for unfavorable anatomy, as there was a concern with regard to increased low dose over larger volume, and thus resulting in increase in mean heart dose and lung doses, as I have shown you in my previous slides. Also, issue of second malignancies was a concern. Thus, field-in-field technique coupled with breath control approaches became standard of care. While other approaches of using newer techniques like tangential IMRT or tangential VMAT or tomodilect were tried, and interestingly these approaches were replicating what we do in field technique. So is it a true evolution, or we are going backwards because none of these techniques have shown superiority over field technique, except for some particular situations like when there is an unfavorable anatomy or patient is not suitable for breath control technique. But one technique probably would be game changer, protons, as this would clearly have an advantage in terms of organ at risk doses. Using protons, excess absolute risk of cardiac morbidity was 0.06% compared to 0.5% using photons, as shown in this dosimetric analysis, where delivery photon plans were compared to deliverable proton plans, which was quite a pragmatic comparison. These are some of the big name clinical trial comparing protons with photons, and after a long time we are seeing trials focused on toxicity outcomes, specifically cardiac morbidity. So clinical utility of this approach is a reality, as we have two centers in India already up with this facility, Apollo Chennai and TMH Mumbai, but because of huge financial cost, very few can avail it. Upon reading the trial protocol, in my personal opinion, I felt that these trials, except the DBCG trial, are simply trying to get an insurance companies to pay for proton beam therapy in America. Sorry, this may be my biased opinion. Looking at the DBCG protocol trial selection criteria, I was happy to see that 3D CRT, also known as FIF, and DIBH resulted in mean heart dose of less than 2 Cray. And their pragmatic trial design will consider patients for proton only if mean heart dose exceeds 4 Gray. So in the preliminary study, only 22% of patients were being considered for inclusion in the trial. Most likely, this trial will be the one to provide the most robust data for the benefit associated with protons. So as mentioned earlier, breath control along with field in field is the most preferred way for cardiac sparing in breast radiotherapy, but don't take my word for it, as I may be biased because I am using deep inspiration breath hold with field in field. In this systematic review of 12 studies and approximately 1000 patients, dosimetric difference with regard to PTV coverage was minimal comparing DIBH and non-DIBH techniques, whereas heart mean dose strongly favored DIBH techniques. So let us first discuss active breath control, and thanks to Dr. Shyam Best for providing these images. In active breath control, a small clamp is placed over the nose and patient inhale through breathing tube. This tube has a valve, and as soon as patient holds a breath, this valve closes. So a switch is held by a patient, you can see here, and she can control the valve via this switch. So operating this way do require patient training and counseling. And what are the limitations of this particular approach? It is difficult to apply in patients with severely compromised lung cardiac functions. It needs extra treatment time and is more labor intensive. Though with careful implementation setup, uncertainties are reduced but can never come close to real-time treatment. So we at our institute use deep inspiration breath hold as a breath control approach along with field in field technique. We do a three-day assessment and training for all left-sided breast cancer patients. We include patients into DIBH protocol if on day 3 amplitude is within plus minus 3 mm of day 2 amplitude on 3 consecutive attempts, and breath hold duration is more than or equal to 80% within plus minus 3 mm amplitude. We may stretch our amplitude boundary up to 5 cm in some cases, and if one criteria is unmet, we do one more day of training before patient is deemed unfit for DIBH protocol. So major limitations for this particular approach are also same as in active breath control. So to smoothen this process of selection, we are in a process of developing a deep learning models which can predict the suitability of DIBH based on simple plain X-ray image of a patient. We have recently presented our preliminary work in Eastro, and we found this approach to be worth exploring further with larger data set, which we are doing. As there is no threshold dose for heart, these patients do need a follow-up, and there are many imaging techniques with their own pros and cons, but most commonly used imaging is transthoracic echocardiography, and as per the latest guidelines from International Cardio-Oncology Society, and depending on the risk, transthoracic echo should be done at 6 to 12 months after radiation for high-risk patients, and all patients should have transthoracic echo by 5 years. Most important is to diagnose early coronary artery disease rather than ischemia for initiation of preventive therapy. So finally, I would like to conclude with these take-home messages. The RT-induced cardiac mortality is not a reality nowadays, and it is almost all the patients who undergo RT has a equal risk of cardiac mortality, and these are being minimized with modern techniques and individualized simulations and risk adapted target selection. There should be a judicious use of IMC irradiation, especially when using older techniques or cobalt 60 machines, after assessing the actual survival benefit. And breath hold techniques are the preferred way to go ahead till we all can afford protons. Thank you very much. And at the end, I would like to acknowledge my colleagues, Dr. Irfan Ahmed, Dr. Rahul, Dr. Ismail Sharif, who have been very actively participating in our DIBH protocol and making it a successful approach. Thank you.